Hello everyone, I'm Dr. Lim from KB Lim Skin Clinic. This is a video on melasma or chloasma, also known as the mask of pregnancy. In this video, I shall be discussing the following topics: what is melasma, causes of melasma, types of melasma, symptoms and signs of melasma, and the management and outlook. So what is melasma? Melasma or chloasma is a common form of facial pigmentation. It has a prevalence rate of between 1 to as high as 50% in some very susceptible populations. It most commonly affects women and less commonly affects men. Men account for less than 20% of the total. It is most common during or after pregnancy and hence often referred to as the mask of pregnancy. It is more common in darker skin types, in particular skin phototypes 4 to 6, which includes Asians, Hispanics, Latinos, and African Americans. What causes melasma? Three factors are believed to play a role: genetics, hormonal influences, and increased vascularity. 1. Genetic factors. A family history of melasma can be found in 50% of patients presenting with melasma, suggesting that family history and genetics are important in the causation of melasma. 2. Hormonal influence. Melasma commonly occurs during pregnancy and in women on oral contraceptive pills and or hormone replacement. Researchers have found increased estrogen receptor expression in melasma skin compared to unaffected skin. 3. Increased vascularity. Blood vessels are often increased in melasma skin. Researchers have found increase in the vascular endothelial growth factor or VEGF in melasma skin compared to unaffected surrounding skin. Further evidence comes from the observation that treatments that have an effect on blood vessels also improve melasma. Melasma can be divided into different types according to the depth of pigmentation and its distribution. Melasma can affect the epidermis, which is the upper layer of the skin, or the deep layer of the skin known as dermis. The type that affects the epidermis is called epidermal melasma, and the type of melasma that affects the dermis or the deeper part of the skin is known as dermal melasma. Some patients have a mixture of both epidermal and dermal pigmentation, and that type of melasma is known as mixed melasma. The location or the depth of the pigmentation is better visualized using a Wood's lamp, which I will discuss briefly later on. There is another type which is very difficult to determine, and that's often called indeterminate melasma, because even with a Wood's lamp you can't really tell where the pigmentation is located, whether it's in epidermis or dermis or both. Melasma can also be divided into different types according to its distribution. The most common form is called central facial pattern, and that affects the forehead, the cheeks, the upper lip, nose, and chin. The malar pattern is the second most common type, and it affects the cheeks and the nose, and the mandibular pattern, the third type, affects the mandible or the jaw. This is less common. The symptoms of melasma vary according to the location or the depth of pigmentation in melasma. In epidermal melasma, the patches tend to have a light to dark brown color, whereas in dermal melasma, it tends to have a gray-brown or blue-gray or blue-brown appearance. And in mixed melasma, you have features of both upper epidermal and dermal melasma. Melasma usually affects the face, as mentioned earlier, but occasionally in some patients it can affect extrafacial sites, including the forearms. Typically, melasma darkens with sun exposure, and this can be quite dramatic and quite alarming, especially in people who have achieved lightening with the treatments, only to expose themselves to the sun incidentally and notice that their melasma has gotten a lot worse. So exposure to the sun should be avoided and sunblock should be used all the time. This is a patient who has this central facial pattern of melasma. Here you can see melasma on the cheeks, on the nose, the upper lip and chin, and also on the forehead, although it is not shown in this slide. This patient here has melasma affecting the cheeks, and this is known as the malar pattern. I do not have a slide of the mandibular pattern of melasma. The diagnosis of melasma is usually made clinically with the aid of a Wood's lamp that I mentioned earlier on. The Wood's lamp helps us determine the depth of pigmentation. If it's in the epidermis, the Wood's lamp illumination would show enhancement of the melasma, and this is known as a positive Wood's lamp examination. In dermal melasma, it does not increase the contrast, so it helps to determine how deep the pigmentation is, because it is important to know this, because if pigmentation is more superficial, the effects of treatment are better, whereas in the very deep form of melasma, which affects the dermis, the results tend to be poor. Melasma severity can also be graded using different scales. The common scales used for research purposes and clinical trials include the MASI scale, which stands for Melasma Area and Severity Index, or the modification of that known as MMASI or Modified MASI. And you'll find links to the calculators in my website in the description below this video. Treatment of melasma can be divided into three main modalities: products that increase skin turnover, lightening products, light and laser treatments. Increased skin turnover, this works by exfoliating the darkened skin, bringing the clearer skin to the surface. Acids used include glycolic, lactic malic acid, jasmin solution, and trichloroacetic acid. Retinoic acid or tretinoin also works by exfoliating the darkened skin. It also has additional effect on inhibiting tyrosinase enzyme that I will discuss again later on. Lightening products work by directly or indirectly inhibiting tyrosinase enzyme or another enzyme known as peroxidase, or they interfere with the transfer of pigment to the surrounding keratinocytes. As mentioned, there are too many on this list to mention in detail, so I will just focus on the main ones that I use for treatment of melasma. So lightening products, as mentioned, there are many of them, and this is not an exhaustive list by any means. The most common product that doctors use is hydroquinone, and this is often used in combination with tretinoin and a topical steroid. In many years ago, Dr. Albert Klickman came up with a formula which combines hydroquinone with tretinoin and the topical steroid. This is known as the Klickman's formula, and it remains to date the most effective treatment. Doctors tend to use a modification of his treatment, which currently, as mentioned, is still the most effective. This is how it works. Hydroquinone inhibits tyrosinase, the enzyme involved in the production of melanin pigment. Tretinoin, as mentioned earlier, increases epidermal and dermal turnover, thus exfoliating the darkened cells, and in addition, it also inhibits tyrosinase, the enzyme involved in the production of melanin. Steroid has an anti-metabolic effect. It reduces melanocyte activity and production of melanin, and it also helps to reduce the irritation or inflammation that is sometimes caused by tretinoin and hydroquinone. Although Klickman's formula is the most effective lightening formula available, it has some risks. Although it doesn't occur very commonly, some patients appear to be quite sensitive to the hydroquinone or the tretinoin and develop an irritant dermatitis, which can result in a burning sensation and darkening of melasma. Prolonged use of hydroquinone in some patients using high concentrations of hydroquinone can lead to a condition known as ochronosis or confetti-like depigmentation of the skin. Because of the steroid in Klickman's formula, prolonged use can also cause skin atrophy, although this is slightly reduced because tretinoin helps to improve epidermal cell turnover and reduce the risk of skin atrophy. But as mentioned, prolonged use will often lead to atrophy. The third group are the lasers and light treatments, and there are many of these, and again, this is not an exhaustive list, And when there are so many lasers and light machines available, this should in a way tell us that no one of these treatments is uniformly effective, and we usually use this in patients who are very motivated, who are very distressed by their melasma, and would like to try all methods in order to achieve some improvement. In addition to treatment from the doctors, there are certain measures you can take to improve melasma. For example, if you are on oral contraceptives and hormone replacement, stopping them can help, definitely. And reduction of sun exposure, as mentioned, even if you achieve lightening, exposure to sun can bring the pigmentation back very quickly, and this can be very alarming. So avoiding sun exposure is important. In addition, one should always apply a broad spectrum sunscreen that blocks UVA and UVB, as well as some physical protection such as carrying an umbrella or wearing a wide brim hat. In addition, the pigmentation can be camouflaged using cosmetics. Unfortunately, melasma can be treated, it can be lightened, but it very commonly relapses when treatment is stopped, so treatment needs to be continued indefinitely. There are research going on to find a treatment that can produce a longer sustaining improvement with a lesser risk of relapse, but this research is still ongoing and we haven't found the ideal treatment yet. So I hope you found this video useful. I would like to thank you for watching, and I would like to invite you to visit our website at www.kblimskinclinic.com, where you can read more articles about common skin disorders as well as melasma in greater detail. I've also provided links in the description to the calculators that will help assess the severity of melasma. Thank you for watching, and I hope to see you again. Goodbye.